have with us Dr. Ritesh Sharma. He is a consultant nephrologist in Asian Hospital, Faridabad. As presenter, we have with us Dr. Alok Sharma. He is a consultant nephropathologist in Dr. Lal Path Laboratory in New Delhi. Isn't any and few more? So, Dr. Alok sir.
And its team. And today we will be speaking about microscopy of the urine sediment. And how do we approach? So there'll be a lot of things to it. We'll see how it progresses. And probably there is a slide seminar on the next week also. So what we learned today as a part of the whole system, we will try to put it into practice in the next week. So beginning, so just a basic background on urine cytology. All of you know it's a liquid biopsy. So it's the most common scientific term used for it. And you'll be surprised to know that this is probably the oldest laboratory test in the history of mankind. And even if you look at the older literature around 4000 BC, there have been records of analysis of urine on clay tablets. So you can go as back as 4000 BC to understand the importance of this. And even in our own texts, in the Sanskrit medical works from around 100 BC also described. So there are a lot of studies. So around 20 types of urine they could identify based on the gross examination and the smell and the taste of it. So probably it's one of the oldest laboratory tests known to mankind. And as you must be knowing, so there are actually three main, if you want to divide urine analysis, there are three main parts. So you have the physical examination, the biochemical examination, and the microscopic examination. What we'll deal today is predominantly with the microscopic part of it. So how do you approach and what do you require? What are the various differential diagnoses you can have based on clinical conditions? Predominantly microscopy based. So the physical and biochemical is not in scope, but we'll deal in depth in the microscopic. Now, as I'm sure you must be doing it in your labs day in and day out. So we examine urine spun in a centrifuge. We were talking about microscopy here. And when you spin it around 1500 to 2000 RPM, the sediment which settles down is the one which is used for the examination, the microscopy exam. And most of the times we examine it fresh, right? It's the best time to do it. You just cover it with a slide, spin it, discard the supernatant, you put it into another tube for other tests, take the sediment, spread it on the slide and view it under the microscope. This is the most common form of urine examination. Just a simple thing can give you such immense information. That's the beauty of doing urine examination. Now, as I just told you, so you can just view it unstained. And the best way to do it is just you lower the condenser of your microscope, and this will provide a greater contrast between the urinary constituent and the background. So just a simple maneuver like lowering the contrast will give you enough information on that sediment for you to distinguish between the various cell types and try to figure out what's happening with this patient. If you want to go into details or you want to actually identify specific subtypes, a lot of staining techniques, the commercially available stains and the other stains are also available in the market, and you can prepare them in your lab also. And they can be specific to cellular constituents. We'll come to that as we progress in this lecture. And if you want to do a more detailed examination, you can even have a polarizer or phase contrast apparatus attached to your microscope, and these will give you a greater depth of examination. There will be certain constituents we can readily examine by using these. For most purposes and for vast majority of urine sediment examination, unstained section with a lowered condenser suffices. You can get a lot of information just from that basic process. Now, to do a good urine examination, there are certain prerequisites that need to be adhered to. And the first and foremost, a very important one is it should be analyzed ASAP. And the ideal time would be within 30 minutes. So if the 30 minutes of collection. So as soon as the vial or the container arrives in the laboratory, the process should. However, if that is not possible, then you can refrigerate it immediately. But you should not be doing this for more than 6 to 12 hours after collection. So that's the maximum time you can refrigerate and reuse for other examination. And once you're doing this, once you take out the refrigerated urine from the refrigerator, it should be thawed, should be carefully brought to room temperature and resuspended before analysis. So you have to do this process. You can't hurry or rush through these processes, because if you do that, the whole purpose of doing examination would be lost. And it should never be frozen. So remember, the urine should never be frozen, particularly when you want to do a sediment or a microscopic analysis on it. And when you have spun the urine, taken the sediment, you should always determine the volume of the sediment. So in your report or wherever you want to do it in the laboratory, and usually if you have a sediment which is more than 0.2 centimeter, it will denote a lot of cellular elements. So if there are a lot of cellular elements and you centrifuge it and you get a sediment which is 0.2, you can be sure that you have sampled a good number of cells. So these are a few prerequisites before you start doing the microscopic examination. Now, coming to the staining or the visualization part, I just told you that most of the times you will not require any staining, and just lowering the condenser on a fresh cover slip uh, slide would give you a lot of information. However, having said that, there are several stains which are available which you can use on the urinary sediment, and the stain which you choose for doing this would depend on the clinical condition in question, right? You can't do this, put so many stains over every specimen. So depending on which clinical background the case has arrived or the sediment has arrived, you can choose to put certain stains. For example, if the patient is in the post surgery period for a PTCA, right? Then you are looking for eosinophils in the urine. So you can put up this specific cancel stain in urine. And then if you are suspecting a patient to have intravascular hemolysis or something like that, then you can choose and put up a hemosiderin stain. So your choice of stains will be dictated by the clinical question or the clinical. Now, this is just an example. So there are a lot of stains which they're general stains. You can use them if you want to look at the cellular elements in greater detail. You want to differentiate them from one another. The S and the SM stain are the ones which are most commonly used. The S stain, yeah, refers to the Sternheimer stain, which is a combination of Alcian blue and pyronine. And the SM stain or the Sternheimer-Malmin stain is a crystal violet and saffron and B combination. So depending on what the cellular, you can see in the picture below. So you can see the red cells which are the urothelial cells, and you can see the hyaline casts and squamous epithelial cells which are written by the arrow. So this gives you different stain to the different characters and makes your examination slightly easier. Having said that, with adequate practice, even in an unstained section, you can easily visualize all these things, right? Now, a very, very important part of doing urine examination, especially when you are dealing with a patient who has a renal disease or something, so he's looking for RBC casts, right? So this is just an example. I'm just brushing you through basic appearances before we go into slight more detail. And you can see these RBC. There is a cast-like structure which has RBCs of varying shapes and sizes and outlines embedded within it. So these are probably degenerating RBC. So this structure is a RBC cast. You can also have RBCs which are embedded in other casts. There can be a cast which is composed solely of RBCs. So you can have mixed casts, you can have RBC casts, you can have WBC casts. And with practice, you can identify them even on an unstained section. And if you're not sure about it, there will be various stains by which you can go ahead and stain them and try to identify the cellular components in greater detail. Now, sometimes what we also do is we can also do a Sudan 3 stain to look at the fat globules with fatty acids. Say a lot of patients with nephrotic syndrome and other things, you can have the excretion of fat in the urine. So sometimes these casts or the lipid droplets are not readily visible. You may actually miss them in while doing routine examination. And if you are suspecting this based on the clinical presentation, you can always use a Sudan 3 stain. It will nicely stain these fat globules or fatty casts and make your examination easy. Similarly, uh, you have WBCs, right? I talked about the WBC casts. And, now the peroxidase containing cells like the neutrophils, eosinophils, you can use a stain called as the Prescott, the PB stain, as it is commonly called. It's called the Prescott Brody stain. It's basically composed of a chemical called as 2,7-diamonofluorenfloxacin B. This is the active component in this particular stain. And what it does is it stains the different components in different colors. So the peroxidase containing cells will take up a bluish blackish kind of, you can see in this picture. And the other cells like the lymphocyte, the ones which do not contain peroxidase in the cytoplasm, will be stained. So you can distinguish between the lymphocytes and the neutrophils or the granulocyte very nicely by using this stain in advance. You can remember these Prescott bodies or the PB stains. So I've told you S stain, the SM stain, the PB stains, a lot of stains which are available for staining the urinary sediment. Now, I spoke about one of the clinical scenarios when I was giving you example of how to choose the stains for clinical conditions. If you are suspecting iron or hemosiderin, you can use a Berlin blue stain. So the Berlin blue is basically composed, it has a potassium ferrocyanide in it, and it reacts with the hemosiderin granules, giving them a bluish indigo color. You can see the stain here in the picture given below. The bluish color structures or the cells are containing hemosiderin, and then you can suspect an hemolytic process which is going on, and the cells are getting stained by iron. You remember, if I ask, I also spoke about eosinophils, right? It's an important thing. One specific clinical condition I gave you an example of in the post. You'll get requisitions from the cath lab or the cardiac surgery unit telling you that please look for eosinophiluria. That's the most common requisition you get in those. So in those cases, it is not a bad idea to do an Hensel stain because you are looking specifically at those cellular elements, and if you can really identify them, quantify them, because these examinations are done serially. So basically, the idea is to exclude an atheroembolic renal disease after PT scan. So atheroembolic renal disease is accompanied by a significant, because it's kind of an allergic response. A lot of eosinophils escape into the urine. That's the idea of doing an Hensel stain. So you can do an Hensel stain. It is a component of methylene blue and eosinophil, and the eosinophil granules stain beautifully red with this. So very easily you can pick up the eosinophil granules. Sometimes it becomes difficult to distinguish between the various granulocytic components on a routine, on an unstained section. So that's when these particular stains are useful. So sometimes neutrophils with large granules maybe become very difficult to distinguish from eosinophils. Then you can use one of these stains to distinguish the various cellular granules. Now, sometimes you have glycogen containing cells in the urine, right? So if you do a Lugol's, the usual Lugol's staining, the potassium iodide stain, so you can stain these glycogen containing cells brownish. So they will be either partly or entirely stained brownish red. So this is also a useful stain when you have a specific clinical question in mind. So these were a few commonly used stains, and as you must have seen, these are all the performance or the decision to do these particular stains is dictated by the clinical condition. But having said that, if you are having a urine lab in your laboratory, the one which does good detailed urine examination, it is not a bad idea to have a general stain and a few of these specific stains which you will do, because these are not difficult make, easily available components. Most of the histology, hematology laboratories will have these stains with readily available. You don't have to buy anything extra. So you can just prepare a stock solution and quickly do these stains as and when the samples are. So this I have already told you. So, but when you do an urinary sediment examination, it is a good idea to do it in a sequential or in an organized manner. So doing it in an organized manner means you look at each and every component one by one and try to do a comprehensive examination of the urinary sediment. So you can have, first thing is we were talking about cells. So you can there will be cells, RBCs, the WBCs, the epithelial cells, oval fat bodies, which I just told you. The next you should pay attention to casts. That's another second very important component of doing a urinary sediment examination. And these casts can be cellular. I'd shown you a few pictures of RBC casts, the WBC casts. So these casts could either be cellular, which contain RBCs or WBCs, or they could even be acellular. The acellular casts are the ones like the hyaline casts, the waxy casts, the fatty casts. They don't have any cellular elements, but they have different components escaping from various parts of the renal apparatus, and they have their own importance. We'll come to that as we go ahead. Now, the third thing which you look at is the crystals. So a lot of crystal inspection in the urine, or the presence of crystals in the urine, is also determined by the pH. Apart from the pH, there will be certain clinical conditions in which you will get various crystals. And when you look at crystals, you should also be aware which crystals are normally seen in the urine. So, and which are the crystals which are not normally seen. And every time you see this crystal, it has to be an abnormal clinical conditions. So, depending on the pH of the urine and other things, you can get uric acid, calcium oxalate, amorphous urate, calcium carbonate, phosphate. So, you can get these depending on the pH and, of course, the clinical condition. So, every time they are not just normal, but there are certain really abnormal crystals like the cysteine, the cholesterol, the bilirubin, leucine, tyrosine, the sulfonamide, which will always be associated with an abnormal clinical background. So you will have to analyze the case in detail. What is the background? What are the other findings? And then you decipher what how much importance you attach to a normal ones will always be abnormal and will give you a good clue to the pathology. The fourth thing you look at in a sediment is organisms, right? So you look at bacteria, the yeast cells, especially the trichomonas if the sample is from a female. And even you can get microfilaria and schistosomas depending on the clinical background of the patient. But just a word of caution here, when you look at bacteria and yeast cells, you have to be sure that your sample is not contaminated or has not been kept for a long time at room temperature without being examined. That can give rise to secondary contamination, and everything has to be viewed or interpreted in the correct clinical background. So that's a very, very important common theme which I am imparting to you. So you just take note of that. And then you will have certain things which don't fall into any of these four categories. Just for example, spermatozoa. You can even encounter spermatozoa in a urine specimen, and in the given clinical, in the correct clinical context, even these have an important indicator of the underlying pathology. So this is just in a nutshell, how you do a urinary examination. If you go through these four or five components in sequential, systematic manner, it is very unlikely that you would miss out on anything, and you will be able to give a good report and help the clinician in trying to understand what's going on. So moving on. So you will see you will have heard of these terms a lot. So what is an active sediment? So when you get requisitions from clinicians, you would get them. Please examine the. Please comment on the activity of the urinary sediment, or you would just get a requisition saying urine for active sediments, right? So you should understand what an active sediment means and what does an inactive sediment means. So if you look at the definition, this is the most commonly agreed upon definition, although there are various interpretations depending on the clinical scenario and the institution you are practicing in. For most general purposes, an active urinary sediment will be defined as the one having more than 5 RBCs and or more than 5 WBCs per high power field and or cellular cast where none previously existed. So you should remember this. So when you do a serial examination, you don't have a cast or cellular element earlier, but when you do a next examination, then you can comment it wasn't there earlier, now it's there. So this sediment has become active. That's one part of it. And on the flip side, the inactive urinary sediment would be having usually equal to or less than 5 RBCs and less than 5 WBCs for a high power field, and it should not usually have any cellular casts. So the cellular casts are a good indicator of sediment. Many times clinicians, especially nephrologists, when they are talking for active sediments, they are expecting you to comment on the RBCs. So you should pay attention to distinguishing between RBCs, WBCs, and other cellular elements very carefully. Now, coming to cells, so it's obvious you can have a large number of cells, the various type of cells in the urine, and some of these cells come from the blood. You must have seen that, and they can even come from the various epithelial lining from the urinary tract. Wherever the urine passes through, these cellular elements can get included or shed into the and appear in the urine sediment examination. So you have the WBCs, the RBCs, the renal tubular cells, the urothelial cells, the squamous cells. And if you remember, there was one stain I told you earlier. We can talk about it later in the seminar if you remember that, which will distinguish between the various cellular types. So those kind of general stains are useful to do when you want to distinguish between the various cellular types in the urine. Now, erythrocytes, probably the detection, the analysis of RBCs is perhaps one of the most important part of doing a urine examination. And many times, it's not just the number or the cast, you also have to look at the morphology of the. And if you really want to define hematuria, I told you, so it's more than 5 per HPF would constitute a significant number of RBCs in the urine. And it is very important to remember that RBCs in urine can be glomerular in origin. So they can arise from a glomerular pathology, but they can also arise from trauma, stones, UTIs, even some toxins which can induce escape of RBCs into urine, and even physical stress in some patients. So it is important to identify and then try to figure out what is the clinical background and then decipher why and how these RBCs are important in the urine. And it is not to mention, you should always exclude any contamination from vagina in women. So before commenting on importance or the significance of RBCs, it's very important to exclude. Very important thing, which is often overlooked by a lot of labs, and you end up giving reports which are unnecessarily alarming and lead to a lot of investigations which are not required. Now, when we talk about hematuria, it is as a pathologist or as a person doing a sediment examination, it is your duty or your it's a very important duty, I would say, to try and decipher whether that hematuria which you are seeing, the significant number of RBCs, are glomerular or non-glomerular. So the best way to do is to look at the morphology of the RBC. So normal RBCs, the ones with normal shape and size, are called as isomorphic, and any deviation from that is called RBC dysmorphism. Like anything else in pathology, there are isomorphic and dysmorphic RBCs. Now, more than 80% of dysmorphic, although it's very controversial, so you really cannot have a cutoff here. But when you have a significant number of RBCs which are dysmorphic, and most of the large number of laboratories take the threshold as 80, then we suspect a glomerular hematuria. So when you have more than 80% of RBCs which are dysmorphic, then it is a strong indicator of glomerular hematuria. That meaning those RBCs are coming into the urine as a part of some glomerular pathology. It could be a proliferative pathology like infection related GA and IgA nephropathy, or it could even be because of GBMs being seen in certain patients or Alport syndrome. So these are the conditions which are useful for determining. We'll come to that, how you determine them. And in this context, I would like to say having a phase contrast microscopy is a very useful tool to detect the morphology of RBCs. So if you have this attachment in your microscope, you can do a very good examination and see the outlines of RBC to determine whether they are isomorphic or they are dysmorphic. Then you go to the percentage of cells. So this is a picture which will you will readily be able to identify on the left side of the screen. There are cells with RBCs. This is a phase contrast. Of course, you can see that halo around those RBCs. This is phase contrast microscopy. Though most of the cells appear roundish, the RBCs. So these are isomorphic erythrocytes. Whereas if you pay attention on the right side, many of them are having spicules, irregular margins, and other things. These are dysmorphic RBCs. So isomorphic versus dysmorphic RBCs is a very, very important part of doing the urine sediment examination. So this will tell you whether the hematuria which you are seeing in this specimen is glomerular or non-glomerular. Now this is a big chart, but what it does essentially does is it shows you a lot of isomorphic and dysmorphic RBCs. So depending on the pH and other things, even some of the isomorphic RBCs can become crenated and other things. And how you distinguish them from the dysmorphic RBCs. So one which I would like to pay your attention to is the number B24, B26, B27, B28. So these are the ones where you have small protrusions from RBCs, so-called dog's ears appearance. So this is a very, very commonly found appearance of dysmorphic RBCs in urine. There are various others, but this is a relatively common theme of small outpouchings of the cytoplasm with irregular margins, which helps you to identify the dysmorphic nature of the RBC. So I've given you the reference at the bottom here. So you can note it down. Go to this article. It's a fantastic article. And you can get a lot of details and study this particular chart in detail when you are actually practically doing the urine microscopy examination yourself, right? Now we've done about the RBCs. Now we'll move on to the next cellular element. So leukocytes are the next important cellular element. And you must have heard this term pyuria a lot, right? So what pyuria does is what pyuria refers to the presence of abnormal number of WBC. We've already talked about the threshold there earlier. That may appear when with infection in the urinary tract. And you should also remember that contamination should always be excluded and actively sought for. And you should always exclude that. And WBCs from the vagina, especially in the presence of vaginal and cervical infections, or in males from the urethra, both in male and female, should may contaminate the urine. So you should be careful of that whole clinical background before you comment on the significance of leukocytes. So abnormal number of WBs in the urine is called as pyuria. That's a common term. Now, amongst the leukocyte, it is of paramount importance to identify the neutrophils because that's what you will see most of the times in urine, and especially in infections which we the urinary tract or the UTIs, which commonly urine examination is done. And if you see them under the microscope, they have an average diameter of around 10 micrometer. And you can see that the granular cytoplasm, the granular site. If you're doing a low condenser or a phase contrast examination, you can actually identify the lobules, the nuclear lobules. So it's not difficult to identify the neutrophils in a urinary sediment. It takes some practice. If you're in doubt, you can always use one of the stains which I have already told you earlier. But most of the times it's not required. You can easily identify the neutrophils in urine. Now, lymphocytes, of course, will not have any granules in their cytoplasm. They will be agranular. And you often find a large increased number of lymphocytes in a lot of chronic inflammatory conditions and a lot of viral infections. So when you have, because in Delhi we have the seasons of dengue and other things, viral infections, seasonal viral infections. When you do urine in a lot of these patients, you will get a lot of lymphocytes. You have lymphocytosis in the urine. So that's one common condition where you get increased lymphocyte. And if you are in a setup where renal allografts are being done, and you are being called upon to do the urine sediment examination in patients who have undergone transplantation, some studies have shown that a gradual or an abrupt appearance of lymphocyturia or abnormal level of lymphocytes in urine, it is an early feature of acute cellular rejection. There have been several studies on that, although the significance and how you do it in practice is slightly different. You can have varying views. But even I've seen personally in cases which I used to see, you do get a lot of lymphocytosis, at least along with the renal allograft rejection. And if you do a careful examination on serial examination, you can actually pick up or kind of predict allograft in some cases at least by looking at the lymphocyte. So this is another way, another utility of doing a good urinary examination. And the picture here shows you lymphocytes, so obviously they won't have granules. And this is just a lowered sediment examination. You will see just round cells. If you go to the bottom of the condenser, you can see a very scant cytoplasm without any significant number of granules. Easily identified. We have covered eosinophils. So these are basically they denote allergic etiology. That allergic etiology could be an interstitial nephritis. You want to look at the drugs which the patient is receiving. I told you the example of atherosclerotic renal disease in the post-PTCA period. It's an important urine examination where you do. And sometimes in allergic UTIs, the fungal UTIs, you do get a lot of eosinophils. And in specific geographic regions like the Middle East and other places, they do a very meticulous examination for urinary eosinophils because Sumia hematobium is a endemic uh, parasite there, and it gives you a lot of eosinophils in the urine when the infection is there in the bladder. So these red cells in the picture on the right side denote. So this stain is Hensel's stain. Okay, so you remember this stain. It's a useful stain, and you should try and have it in your lab if you are doing a good urine treatment. Now, coming to the tubular cells. So you can also get a lot of tubular cells in urine, and you can identify them. They are mononucleated cells, easily identifiable, and they're slightly larger than the usual lymphocytes or the neutrophils. As the neutrophils would be around 9 to 10 micron, these are slightly larger, 13 to 14 microns, and they can be rectangular, polygonal, or columnar depending on where they are arising from. An increased number of these cells is usually seen in acute tubular injury or acute tubular necrosis. And you can even get a large number of, because they shed off because of inflammation, they have a tendency to shed off from their surface epithelium and they appear in the urine. Interstitial nephritis, and if you're looking at the urine from transplant patients, again, they are found in increased numbers in allograft acute cellular allograft rejection. And sometimes you can find an increased numbers even in a nephritic or a nephrotic syndrome because you can get shed from the epithelial line. Now, you can even see urothelial cells, and by their morphology, you can identify whether they are arising from the deep urothelium or arising from the superficial urothelium. So you know that the superficial urothelial cells are pretty large. They're almost 25 to 30 microns in diameter, and you often see them in large numbers in urinary tract infections. Only the idea of identifying them is you don't confuse them with other cellular elements and make a wrong diagnosis. So that is the reason why you should be able to identify these urothelial cells also. Whereas the deeper cells, the ones from the deeper layers of the urothelium, are much smaller, 15 to 18 micron in diameter. And you can find increased numbers of these cells in renal stone disease, hydronephrosis, patients who have got stents or prolonged catheterization. You get a lot of deep urothelial cells because of this reason. So it is a good idea to differentiate between still and deep urothelial cells depending on their size and shape and morphology. Now, these are the most common cells. The squamous cells, every urinary sediment will have occasional, at least, squamous cells in the urine. You can identify them by having a very copious amount of cytoplasm and a small nucleus. And they are the largest cells in the urine. You can easily identify them. And why you find them is they are usually exfoliated from the urethra. So small number of them you may find in almost all the urinary sediments. But if you see them in larger numbers, then usually either they are a part of the contamination or they are a part of the vaginal discharge in female patients. So that's the importance of looking at or identifying squamous epithelial cells. So you've done the cellular part of it. Now you also have a lot of other things which you should be aware of, theoretically at least. And whenever the chemical condition arises, try to actively look for these particular things. So of these, lipids is an important finding which you should be able to identify in the sediment. And when you look at them in the urinary sediment, they usually appear as droplets. And these droplets could either be single, they can be scattered here and there, and they can even form a conglomerate by themselves, or sometimes they can even get incorporated into the cast. So most of the times you will find them in WBC cast or the RBC. Even in RBC cast, you can see them depending on what the clinical condition is. And when they are in cast or cell, they can form oval fat bodies. So what are oval fat bodies? Basically, these are tubular cells or even macrophages, for example. And lipids are in the cytoplasm of the cells. So because the lipids are so much in amount and they form aggregates, they start appearing as oval fat bodies. And when you want to identify these oval fat bodies, a very good examination is doing it under the polarized light. So when you see them under the polarized light, they appear as nice Maltese crosses. Like I'm sure I'm having some picture of this. These are Maltese crosses which are seen. So the oval fat bodies appear as Maltese crosses in the polarized light. And when you come to the etiology, they are seen in abundance in patients with nephrotic syndrome for obvious reasons. And in some patients with polycystic kidney disease or even with non-glomerular disease, sometimes you may see escape of lipid in urine. And if you see them in very unusual conditions, you can actually diagnose disorders of the lipid metabolism. For example, in Fabry's disease, you can see these fat bodies in oval fat bodies in large numbers. So this is how it appears. So these are labeled. So you can see a lipid cast on the left extreme, an oval fat body in the center. And when you polarize this particular thing, these are the nice Maltese crosses which you're seeing on the right side. So it is easily identifiable and a very, very useful test to do a polarized examination to identify the oval fat. So when you have lipid in urine, it is called lipiduria. You have pyuria, you have chyluria, you have lipiduria, you have hematuria. So all these things you should be able to identify. Now, one of the last things there, so the casts, we talked about the basic stains, we talked about the cellular elements. Now we come to the casts. Examination of casts again is a very, very important process when you do an urinary sediment examination. So how do you identify casts? Casts are basically elongated. They are usually elongated, so it's easily to identify them. So most of them have a cylindrical shape, and depending on where they are formed in the urinary tract, they will have various shapes. So because of bending, wrinkling, and various morphological alterations they undergo when they're passing through the urinary tract, they can have various morphology. But the common theme, most of them are cylindrical and elongated in appearance. Now, you must have all heard about this TAM protein. So this forms the matrix of most of the casts. So this TAM protein, you please pay attention to the spelling. So a lot of it is not horse as in horse, it is horsefall. So you don't E here. TAM protein. Basically, it's a glycoprotein which is secreted by the thick part of the ascending loop of Henle and also by the early distal convoluted tubules. And if you look at the urinary protein, this particular protein constitutes almost 1/3 of the total urinary protein and forms as I've told you, forms the matrix, the skeleton of all the casts is formed by this TAM protein. So what this protein does, it forms a meshwork of fibrils. So what these fibrils do is, so they have the tendency to entrap any cellular elements. Whatever gets to the tubular filtrate, these casts can just, because of their fibrillar arrangement of their meshwork, they just entrap them and then give a character to that particular cast. And because of that character, you can identify what is the pathology. It's a beautiful thing. So everything is arranged in concert for you to be able to identify it under the microscope. Now, if you want to classify, so classification basically helps you to do a good examination so that you don't miss out on anything. And if you look at it from a different angle, you can classify these casts as matrix casts. So they are just composed of that basic matrix, which are hyaline or Vexi or whatever you want to call it. And when cellular elements get added to it, then it becomes an inclusion cast. So you can have protein, cell debris, cholesterol esters, hemosiderin, or even sometimes you can also get crystals within these. So we'll just quickly brush through the basic casts so that you have a good understanding of how they appear and what they are arising from. So the most common cast is the hyaline cast. So you will see them in almost every urine sediment. And these hyaline casts are almost entirely composed of the TAM protein. When you talk about hyaline casts, you're talking about the TAM protein. And unfortunately, they have a very low refractive index, so not easily visualized. Once you lower your condenser to sufficient depth, you can identify these hyaline casts. And if you want to visualize them the best, of course, the phase contrast microscopy is the best. So as I told you, they can be normally seen, right? But when there are certain conditions in which you find high number of hyaline casts. So if you see an abnormally high number, these are the clinical conditions where you should be guiding the clinician to. For example, exercise, use of diuretics. Sometimes with heat exposure and dehydration, you get a large number of these hyaline casts. That's a very good indication of metabolic state of the patient. And in children or patients who have a urine examination during fever, you can get a large number of these. So be able to identify first number the cast and try to decipher if there is anything abnormal in terms of clinical presentation. The waxy casts, on the other hand, are slightly better visualized even on routine microscopy. And many times in chronic renal diseases, they become denser and they are appear as waxy casts. And just like the previous casts which we have seen, they are associated with tubular inflammation and degradation. And you must have heard about these renal failure casts, right? Somebody can ask you in your viva and other things, what are renal failure casts? So what are renal? These are nothing but these are waxy casts which are big, they are very broad. And since most of the times, these casts are abundant in patients with chronic renal failure, they have also been called as renal failure casts. Well, they are nothing but large waxy casts. What it implies is basically when there is an advanced tubular atrophy and or dilatation, of course, depending on the what the state kidney is in, and the large number of these casts basically denote a lot of chronicity in the kidney. So that's the reason they are called as renal failure cast. They are seen in patients with irreversible renal failure. Sometimes you can have a mixture of these. So you have granular elements embedded onto a hyaline cast, and you can have fine granules embedded on those that skeleton of the hyaline cast. And a lot of patients with varying etiologies of glomerulonephritis, you can get this hyaline granular casts. You must have seen in your urine examination. Whereas granular casts are almost predominantly composed of granular material. So these originate from plasma protein. So both, what these granules are basically composed of plasma protein aggregates that pass on into the tubules from the damaged glomeruli. And many times these granules are also composed of cellular remnants of WBCs or RBCs or damaged tubules. So you don't see the cellular elements themselves, but you see remnants of their cytoplasm. So they constitute the granular cast, and they have a wide etiology. So they can see in globular disease, tubular disease. So they're not very specific, but they do tell you that a lot of inflammation and degradation and damage is going on in the entire renal urinary tract as well as the renal parenchyma. From that point of view, they are very important to be recognized. We've talked about the fatty cast. So when you have a lipid material which is incorporated into a cellular matrix, they form those lipid-laden casts. And many times, when patients have nephrotic syndrome or heavy proteinuria, you will find these fatty casts in abundance in urine. Then they're composed of cholesterol esters, malty, and I told you, when you just put the polarizer and cross polarize it, they give beautiful Maltese cross appearance. So you can easily identify these fatty casts in urine. And of course, so as I've told you, any cellular element or any element in urine can get incorporated into that cast. And depending on what the crystals are there in the surrounding, these crystals can get just entrapped into those meshwork and form casts of the same name. So if you have a lot of uric acid or calcium oxalate crystals in urine, or they are coming from the tract, they can appear in the urine sediment as casts. Now, coming to pigment casts. Sometimes what happens, depending on the clinical conditions, these casts pick up certain color. So depending on that color, how you can identify the etiology. So you can have myoglobin casts. So myoglobin, will appear when there is muscle injury and damage to the kidney. So you can have myoglobin casts in the renal parenchyma on the biopsy. And similar casts can appear in the urine as myoglobin casts, right? They're brownish in color and are often seen in myonecrosis or rhabdomyolysis it's not an uncommon thing. And we often come across this in clinical conditions. Various drugs, prolonged exercise, heavy unaccustomed exercise can give rise to myoglobinuria, and the myoglobin cast can be seen in the urine. Similarly, with patients who have got renal dysfunction, liver failure, you can get these bilirubin casts. These casts get stained by the bilirubin pigment and appear as golden brown colored casts. And immediately, the moment you see them, you know that the patient has liver dysfunction, and they're commonly seen in obstructive jaundice, even in acute hepatitis. You can see them. And if you look at the biopsy of these patients, many times you can even find these casts in the tubules. And that time we call this bile cast nephropathy. So these myoglobin and bilirubin casts are the two most important pigment casts that you may be able to identify. They'll give you a good clue to the underlying clinical condition. we've talked about the pigment casts, and similarly, you can get hemoglobin casts. So depend if there is hemoglobinuria or even hematuria, you can get these intact RBCs or dysmorphic RBCs in the tubular casts. So this is what I was talking about, the RBC casts. So we've talked about trying to distinguish between the glomerular versus non-glomerular origin of hematuria. But remember, whenever you see RBC casts in urine, most of the times the origin would be in glomerulus. So it's a very good sign of glomerular hematuria. So it is a very, very useful exercise to actively look for RBCs casts in urine. They're a very specific and reliable marker of glomerular hematuria. Numerous conditions. So if you want to just name a few, IgA nephropathy, any kind of acute glomerulonephritis, lupus nephritis, renal infarctions, even in severe pyelonephritis, sometimes you can get these casts. And it is when you follow up patients with SLE, for example, when a clinician sees a patient with SLE and follows it up, you can't do a biopsy every time, right? In these patients, so you follow them up with regular urine examinations, and finding of RBC casts in a relatively asymptomatic or asymptomatic patient is a very good marker of an impending relapse of this. So you must have seen rheumatologists, other clinicians who deal with SLE patients doing serial or routine examination. They will ask their patients to undergo a urinary examination once every month and come to them for follow-up. Whenever they see that the patient is having RBC cast in urine, they will immediately take all the actions and see whether that patient has got flare and take further action. So it's a very good screening test in these patients. You are the one who will diagnose and activate that chain of events which will lead to correct treatment in these patients. Now, just like RBC cast, you can have WBC casts. They are all embedded within the same matrix. And as far as the clinical condition goes, they are found in a lot of cases of acute interstitial nephritis also. But with many patients with severe UTIs, you will find this cast. So apart from the leukocytes which are lying free in the urine sediment, you can have these leukocytes which are embedded in the cast itself. And what they do is basically they tell you that the renal parenchyma is pretty significantly involved by the infectious process. So it's a very important examination. Similarly, you can have epithelial cast because of various conditions which I have enumerated earlier. Tubular necrosis, the interstitial, they're not very specific, but you need to distinguish these epithelial casts and not to mix them up with the various other cellular casts which have a very specific clinical indication. So that's the idea of identifying these casts, but to confuse them with other cellular elements. Now the last part. So we've covered the basic pathology, right? We've talked about the cellular elements, we've talked about the casts, we've talked about the various kind of casts which you can see, and then we come to the crystals. Now, looking at crystals and identifying them in the correct clinical context is also a very useful or important part of urine sediment examination. And it is useful to remember that these crystals are from a precipitation of urinary salts, and there are numerous factors which affect this. So pH, temperature, the urinary concentration. So what these things do is they affect the solubility and cause their precipitation. And if you do a lot of examination, you can see that even in a given urinary sediment, you can have multiple casts. So you can have a urinary sediment which will show you uric acid crystals along with calcium oxalate crystals, and even amongst oxalate, you can have both types of oxalate crystals. So simultaneously, a lot of crystals can be present in the same urinary sediment, and importantly, they can be found in both acidic and alkaline urine. And to some extent, the type of casts also will appear depending on the acidity of the urine. And what enables us to identify them is their bifringent nature sometimes. So some of these crystals are pretty dramatically birefringent. For example, the uric acid and the calcium oxalate crystals. So it's easy to identify them in the urinary sediment by virtue of their birefringence. So you didn't even have to take up a polarized light or anything. You just lower your condenser to the bottommost point, and these crystals will shine up very brightly into the urine sediment. Easy thing to identify. So this picture which I have told you, so these are very dramatic. So even in a routine sediment, you can see the larger picture shows you partially polarized or a down condenser. And when you polarize it, it shines in dramatic colors. So these are uric acid crystals, and they precipitate when the pH of the urine falls below 5.4. And they are usually in the form of lozenges. So they look like lozenges with a light amber, bluish, greenish color. And what they do is the importance of identifying uric acid is it is a marker of increased nucleoprotein turnover. For example, if the patients having tumors or who are undergoing chemotherapy for leukemia and various other disorders will have increased amount of uric acid crystals in urine. Of course, the various primary conditions of hyperuricosuriia and other things, not to mention that, even the other conditions you should also remember. And they can even be a evidence of a uric acid stone which is lodged in the urethra. So these can get dislodged from there and appear in the urine. And gout, of course, is the most common condition where you get they have got diagnostic significance. So apart from gout, you should also remember the other conditions where you can get large number of uric acid crystals in urine. These are probably the most easily identifiable crystals, but have a lot of clinical significance attached to them. Now, oxalate crystals are probably the most common types you see in urine. And if you do urine examination, you would have seen. So the envelope kind of crystals which you see are the bihydrated dihydrate or bihydrate calcium oxalate. Always remember. And these are the ones which are strongly birefringent. Whereas on the other hand, if you look carefully, sometimes you will find these dumbbell shaped crystals which I've shown you in the lower picture. And these are monohydrated. And these do not show as dramatic birefringence as the bihydrated crystals. Sometimes actually they don't show any birefringence at all. So although both of them are composed of calcium oxalate, it is the hydrogen which is attached to these particular basic structure determines their birefringence. So monohydrate ones are the ones which do not show birefringence. The ones which are bihydrate have the typical envelope shaped appearance and are strongly birefringent. So if you look at the clinical conditions, you get them in hyperoxaluria, you get them in large numbers in CKD, and if you want to really go into the toxicological part, and a very not uncommon is the ethylene glycol poisoning. So it's a good indicator of ethylene glycol poisoning in the correct clinical context. And a lot of indigenously used drugs, for example, like Evora carambola. So some places in the country, it is used as a drug or a toxic or even as a herb. So these patients land up with a severe oxalate toxicity or hyperoxaluria, so as to call it, and you can easily identify it in the urinary sediment. And even in patients who have had small bowel resection, because there is a shortening of the bowel, so there is increased absorption of oxalate. So even in those conditions, you can get a large number of oxalate crystals. For example, in Crohn's disease, so because of the same etiology, that one is surgical, this one is pathological. You get a large number of oxalate crystals. So remember the etiologies, remember the appearance, remember the birefringent natures, one which are strongly birefringent versus the ones which are not birefringent, and why, and which are the monohydrate and the dihydrate forms to be able to identify. Now, just a word on a few abnormal crystals. So these crystals, whenever you see, they will be abnormal. So you don't get them in normal. In contrast to oxalate, which we have seen just now, which can appear even in normal urine, depending on the pH and other things. Sorry, these crystals are always abnormal. Seen is one of the most dramatically visualized or seen crystal in urine. And as you may say in the picture, it is a thin hexagonal, and unfortunately, these are bifringent. Not difficult to find them; they are easily identified. And sometimes they are isolated, and sometimes they can form large clusters. So they just heap upon one another. And then once they're heaped up, it becomes slightly difficult to identify. Then you go around and see if any isolated forms are there. Then you can identify these crystals. And these are a very good marker of cystinuria. So it is an uncommon disease, but you can identify them in cystinuria. And they can also be shed from the cystine calculi, which are lodged in the renal. And interestingly, or importantly, they are just like what we talked about the uric acid crystal. They are found mostly in acetic. Now, it is having said everything what we talked about. So you should at the same time be able to identify crystals which are due to certain drugs. So certain drugs which are given to the patients are crystalline in nature, and when they appear in urine, they can cause a lot of confusion with other things. Not only that, Now, based on the morphological appearance in your LNT, you can identify which drug is the culprit in causing the pathological symptoms. So, amongst these crystals, so-called, you can the one which I have shown you as an example in this picture is a sulfur-diazine crystal. It's very common. So these drugs, sulfur-diazine is a very common component of a lot of drugs and antibiotics given to patients. It can appear so they like broom-like appearance of these crystals, fine in needles, and they appear aggregate themselves in form of broom-like appearance. So this is sulfur-diazine. Similarly, a lot of drugs like acyclovir, indinavir, triamterene, I'm not showing you the pictures here, but a lot of these drugs can also give rise to their corresponding crystals in the urine. And if you have a good clinical background here, so for example, the patient is in retroviral positive, then you can try and look for acyclovir or indinavir crystals. The patient is on vitamin C, you can get a lot of oxalate crystals. And even antibiotics like amoxicillin can give rise to crystals in the urine. So the important thing to remember what the drugs the patient is taking. When you take a history going back, retrospective, or even as a routine part of your urine examination request, you should always mention, you should ask the clinician to tell you what drugs the patient is on so that you can do a more focused examination trying to look for those particular drugs in the urine. Now, cholesterol crystals, of course, so the same on the same lines, you can also get cholesterol, and these are slightly difficult to identify because they don't have a good refractive index. And unless you do a polarized examination or really low the condenser in light, sometimes you just may just miss them. So they are flat plates. You can see one of them. This is a polarized light example. So you can see even in polarized light, they are very difficult to identify. But with a good experience in eye, you can identify them also. And basically, what they have, they have sharp edges and corners. So that's a very useful way of identifying these crystals. And they often keep a company of other lipid particles. So that's another way of suspecting them. And the phosphate that you can have a triple phosphate that often like appearance of triple phosphate, ammonium biurate. So these are the normal crystals. You can get them in, also get them in normal urine. But the ones which are absolutely abnormal always are bilirubin, cholesterol, cysteine, leucine, indinavir, acyclovir. So you can see in maybe you can take a screenshot if you want and keep these in your record. So whenever you get a case next time, you can identify these. Sometimes what happens if you remember, see, for example, if your patient has liver failure and there is bilirubinuria in the urine, so anything which appears in the urine will get stained by bilirubin. So then they become very difficult to identify also. But you should remember that even pigments which are secreted as a part of the pathogenic process can give a different pinch to various urinary components. So you can have a calcium oxalate crystal which is tinged with bilirubin and all that stuff. But then it will help you to identify if there are two pathologies or the basic pathology which is underlying. Right? So these crystals which are appearing colorless may not always be colorless. They can also be affected by the pigments which are there in the urine as a part of some other pathological process. Please remember that. Because I've seen students asking me sometimes, oh, sir, this is colored. How can this be oxalate? So it can get colored depending on which clinical condition it is. Now the last part. So we've done with the cellular elements, we've done with the crystals. Now coming to microorganisms. So after you have excluded all the contamination and inadequate preservation and everything, you should be able to identify or put clinical relevance to what your findings are in the urine. Right? You can see bacteria as rods or cocci, and if you see them in company of a lot of leukocytes, you have a pyuria, a lot of bacterial colonies, then you can correlate the two. Right? But if you have too many colonies and less of cells, then you might start thinking in terms of contamination. So this is how you see each case on its own merit. So you don't just directly go, oh, there are a lot of colonies, this patient is having UTI. It may not be the case, right? And just like other castes, So even I've seen in patients who have got severe acute pyelonephritis, you can actually see bacterial casts. So you will have gamma protein casts in which numerous bacteria are actually embedded in it. So just like any other cast, you can have bacterial casts also, and they usually indicate a severe pyelonephritis. Similarly, the same basic algorithm would go for fungi also. You need to exclude the contamination. And Candida is the most common or most frequently found yeast form in the urine. And more often than not, it is a contamination from the genitalia. And because, it grows in the urinary tract and in patients with diabetes, indwelling catheters, prolonged antibiotic therapy, or even patients who are on a lot of immunosuppression. And if you see them in cast, then again, whenever you see certain things as a part of a cast, then they have more clinical relevance. If you can find candida casts in patients with renal candidiasis. So patient has candidiasis in the urine, and when those pass through the tubular epithelium, they get embedded in those thiamosphal protein casts and appear as candida casts in urine. So they are a very strong indicator of renal candidiasis. Similarly, parasites. So this is an endemic. We don't see too much of it in this part of the world, but in Middle East, it's a very common parasite, Schistosomia hematobium. They are identified by their typical appearance of a conical posterior end, which tapers into a delicate spine. You can see it in the lower part of the picture. This is a very specific appearance of a schistosomia hematobium in the urine. So this is how it is. So we've covered most of the parts here. And I'll just stop for a second here if you want to note down or take a screenshot. These are a few good references which you can note down and do a more detailed, comprehensive study. Thank you. So that's all from my side. And now I invite our moderator, the chairperson of this session, Dr. Mayuri Trivedi, for her comments and questions. Thank you. Thank you so much.
Thank you, Dr. Alok. That was always a pleasure to hear you speak. And it was a very good revision for me also. So I think I totally agree with the first point that you made that, you can, as a nephrologist, as a clinical nephrologist, the urine routine is like a liquid biopsy for us. So actually, before we biopsy a patient, we are very restless without a good urine report, because a urine report is actually going to define whether it's the glomerulus which is going to be involved. Are we looking at the tubulointerstitial pathology, or is there an underlying vascular? Because these are the three components, broad components, under which we would divide the kidney under. So definitely a good urine routine with the three components, so that is your biochemistry and your microbiology and your cellular components, is what is going to give us the further kind of not only a diagnosis as a, are we dealing with a glomerular disease, it's also going to subspecialize it, as in, is this a nephrotic syndrome, is this a nephritic syndrome? So it becomes very important for us to not only know the cellular components, it along with the dipstick findings. So a few things from the clinical point of view that we would say, that there can be a false negative test for blood, that is hematuria. So if the patient is on vitamin C therapy, or if the patient is taking an ACE inhibitor drug called as captopril, or if the patient has a pH of the urine which is less than 5.1, so in all these cases we will have a false negative hematuria on the dipstick. That is, the patient does have hematuria, but it will show a false negative. At the same time, we can have a false positive for hematuria if the patient has a concentrated urine sample. So these are things. So this is where the urine routine is going to make us wiser, because when we do the dipstick, it's going to be showing no evidence of blood. But when you are seeing the cellular components, you are going to say that there are RBCs or RBC casts there, which will kind of indicate that, okay, there is something that we need to go more in detail about the drug history. So as Dr. Alok rightly said, that the clinician needs to give you a more detailed history, especially if you are, if patients come to you with unexplained renal failure and you are thinking in terms of a drug induced, you need to write that down. We need to write that down in the history, saying that this patient is taking all of this. And I would like to share a case that Dr. Alok Sharma does all of my renal pathology, so he knows all of my cases. We had a patient, an 82-year-old patient, who came with an unexplained renal failure after an angioplasty, after a cardiac angioplasty, and we had to biopsy the patient. Unfortunately, the urine routine which is available commercially is not as specific as a renal pathologist would do it. Most commercial labs would just do a dipstick and probably, and they missed the cholesterol crystals. And on the biopsy, I this was a case around 3-4 years ago, Dr. Alok Sharman, you had called me and said that did the urine show cholesterol this thing, because I'm seeing a lot of it on the biopsy. And the diagnosis was what was called as an atherosclerotic renal disease, which had happened post the coronary angioplasty which was done. So again, here retrospectively, we went back to our pathologist, and we went back, as nephrologists, we went to the pathology lab and we spun the urine, and we kind of took the sediment and we saw it, and we saw the cholesterol crystal. So I remember feeling very bad that, as clinicians, we don't examine our urine so often. Once we kind of pass out, as students, we do it ourselves, but as we grow older, we get a little lazy there. And maybe we could have not biopsied this patient and come up with an investigation. So that is what the importance of a urine routine is, and wherein I totally agree that we are more at fault because we give very haphazard histories to the pathologist. Maybe if we write it more in detail, they would be more astute about it and give us better reports. The other thing, that the point that I want to make, is what Dr. Alok just said, that is about the urinary tract infections. So if you see a lot of bacteria and without the cellular elements, without the WBCs, it's probably a contamination. So, and we have a lot of patients who come to us and they say that there's a lot of bacteria in my urine, and is this a UTI? But this is where the pyuria would make sense. These patients, correct me if I'm wrong, Dr. Alok, but these patients, if contaminated, would have the epithelial cells, but they won't have that much of the pyuria which is there.
Pyuria, absolutely.
Yeah. So, just seeing a lot of epithelial cells and bacteria and not seeing the pyuria, you're probably not wrong in asking for a fresh sample, because this is a contaminated sample. And unfortunately, we don't take the time to explain to the patient, the midstream sample and how you clean the private parts before collecting the urine. And there can be, and this patient would be subjected to antibiotic therapy for eternity, and probably contribute to the drug resistance that's happening right now. At the same time, if you don't see bacteria and you see a lot of WBCs, that also becomes very important for us, because there are so, which we call the sterile pyuria. So it could be drug related, means interstitial nephritis, or it could be GU cox, or again the fungi can do that. You won't have bacteria, but you might have pus cells. Now, essentially, in our teaching, yeast is something that is either a contaminant, or if the patient is diabetic. But we have a new class of drugs which is very, very in vogue right now, which are called as SGLT2 inhibitors. And the mechanism of action for this drug, this is a drug which is used in diabetes, it is used in kidney disease, it was marketed as an oral hypoglycemic drug, but now it is known to have kidney as well as cardioprotective effect. And the mechanism of action is it causes glucosuria. And because of the glucosuria, we see a very high incidence of candida infection in these patients. So you may not be wrong if there is a lot of candida or a lot of yeast on the urine, to call back your clinician and ask him whether the patient is on SGLT2 inhibitors, because we are seeing a much higher number, almost which has gone up by tenfold after the introduction of this particular class of drug, which is there since the last probably 5 years. So and this needs to be treated. This is symptomatic, and it is because of the mechanism of action, because otherwise, as Dr. Alok said, we wouldn't treat yeast unless the patient is symptomatic, or there are very specific indications for treating the yeast. So this would be my take on urine. This would be my take on urine examination as a nephrologist.
Thank you so much, Dr. Miri. That was really informative, and a lot of clinical points were elucidated, which will be very useful for the students as well as going forward in the practices.
Thank you, Dr. Mayuri, for your inputs. And thank you, Dr. Alok, for this very informative session. Sir, we have a few questions. Chitravati, Dr. Chitravati has asked, how do you differentiate between RBC and lymphocytes in urine, especially in macrocytosis?
Okay. So the one good way to do it, when you have confusion, see, the basic thing is, of course, size. So when you talk about microcytosis, when they become equal in size, but even if you look carefully at the sediment, lymphocytes will at least show some cytoplasm in them. So if you do the bottom condenser examination and a phase contrast examination, you can identify a small rim of cytoplasm even in lymphocytes. RBCs, of course, will not have, and it is apart from that, the halo which the RBC produces is the halo which a lymphocyte produces on lowering the sediment, or even in a polarized setting, is different. So it's not too much of a difficulty in identifying RBCs versus lymphocytes.
Dr. Alok, can I ask a question here
Yeah,
as
sure.
a nephrologist to you? Is we had the older editions of our nephrology textbook saying that you could differentiate between a lymphocyte and an RBC with the MCV. So, is it possible to measure the MCV of this? You know, less than 72, more than 72 was what? These were the older textbooks. I don't know whether this is in vogue right now, or is it possible to measure the MCV of these cells?
We don't measure the MCV on microscopy, but you can always measure their size.
Okay.
So the RBCs are usually around 7 microns, and the lymphocytes are slightly larger, 10. So based on, but the question here was when the RBCs themselves are large, like macrocytes,
Yeah.
and they become equal to lymphocytes,
Yes.
then it may be a difficulty. But yes, so the MCV is an indirect indicator of the
Yeah. So, and this
size.
is not that, you know, this point is not there in our newer textbooks beyond 2011, 12. But the older textbooks had this point.
Yeah.
So something that I remember reading. So it
I
isn't.
understand.
It's I don't know whether it's even done as of now. But as you said, the size would help us differentiate, unless there is macrocytosis.
And if you're doing so I think the previous text did not focus too much on so polarizing microscopy resolves a lot of things. And
Yes.
so you have you get very good overview of the morphological finding, then you don't have these confusions.
Yes. Yeah.
Yes, sir. Thank you, sir. Sir, we have another question. Dr. Mrinalini is asking, aren't a few renal tubular cells commonly seen in children, and up to how many?
Yeah, so occasional ones you will be seeing. So if you look at 4 or 5 high power fields, you may come across an occasional cell. So there is no real statistical cutoff as to say, but an occasional renal tubular epithelial cell in children can be a normal finding that way.
Right, sir. So again, Dr. Mrinalini is asking, is it okay to report mixed casts or mixed cellular casts?
Yeah, of course, absolutely. So if you are able, that shows you that you're doing a very meticulous examination. So if you can identify the various cell types even within a cast, and that's what you find most of the times. So even in an UTI or even other things, most of the casts are composed of a mixture. So there will be one dominant cellular element, but there will be other elements also interspersed along. So mixed cast would be it's a very good way to do it, and you should definitely report it.
Right.
But make sure to tell what is the dominant component. So that would be a more beneficial thing to the clinician. Suppose if you have a mixed RBC WC cast or something like that, you should tell what is the dominant component in that. It would be an additional.
If I could give a clinical example here, if there's a mixed cellular cast which has predominantly RBCs and a few WBCs, I would think more of a lupus nephritis. If there is more of WBCs and less of RBCs, I would think of urosepsis or a UTI. So if I can get this on the urine, and the clinical picture is going to be the same. The patient can come with fever, the patient can come with hematuria, the patient can have dysuria. So hematuria without infection also can present as dysuria. So this would be the importance of actually categorizing the mixed cast, because it would give you some idea whether you're dealing with sepsis, urosepsis, or you're dealing with a glomerular disease like lupus nephritis, which can have WBCs and RBCs.
Right, ma'am. Right, sir. Sir, you mentioned a lot of stains in your slides. So, what are the references? Like, how do we do those stains on the slides?
So I had given a few references at the last part of, I don't know whether you can get them. So if you follow these, you will get them.
So they also have the procedures for the staining?
Yeah, so you will find them in most of the conventional books of urine examination. Yeah, so these are not unusual stains, but if you search by their name, you will get them. But they're commonly found in most of the standard textbooks of laboratory medicine.
Right, sir. Sir, and what's your experience with the automated urine analyzers that we have?
So I think I'm not probably the correct person to answer that question because I don't deal with that in my practice.
Right.
And yeah, probably we'll have better people who are doing it, probably biochemistry background people, other people who are dealing with it.
Okay. Thank you, sir. Dr. Bonita, you can end the session now.
Thank you so much, sir, for such informative session. Sir, I have a question. Sir, from my personal experience, I've seen some accidental findings like scabies mites in urine. So many times I have got that. Sir, should we report or not, sir?
Yeah, see, I don't think that we should be hiding anything. That's one part of it. But secondly, important thing is putting them in the correct perspective. So you should always go back to the patient because obviously they will not come through the urinary tract, right? So they will obviously come from somewhere else. So you go back, see how the sample was collected. You may actually be able to diagnose something which is coming as an accident into the urine also. And that could also trigger a good clinical diagnosis. So that way you should go ahead and report it. But having said that, you should always get back to the patient and clinician and see how that sample was collected and what is the clinical condition. Right.
Sir, another question, sir, from my side. Sir, so what are the conditions where we get only WBC cast but not WBC? Because
see what happens. There are two phases of a urinary tract infection, right? One is the acute phase,
yes, sir.
and then when you give antibiotic therapy and other things, that becomes subacute, or sometimes it can become a chronic. So if you're looking at a sediment in a real acute stage, you will find a lot of cellular free elements as well as casts. But as the infection becomes slightly older, you may stop getting a lot of free WBCs in the urine and you will start getting more of casts. So those are you can correlate them with the progression, how the patient is progressed. But this is the basic reason behind these findings. That way.
Thank you, sir. Thank you so much, sir. Sir, our box is full of thankful remarks. So
thank you so much. It was a pleasure, and thank you for giving me this opportunity to connect with students all around. Thank you so much.
And thank you so much, Dr. Mayuri.